one of the most common reasons for incontinence is often related to previous surgical intervention on their prostate gland, be this for benign prostatic disease or one of the older operations such as a TURP or a Holette procedure to release their flow, to make their flow faster, or alternatively surgical options or radiotherapy options for management of their incontinence due to prostate cancer, such as robotic prostatectomies or radiotherapy. Other reasons are, and this is often the stress incontinence type, so that's when they leak with coughing or sneezing. The other type of incontinence the men can have is also urgency incontinence. This is where they get desperate to go for a pee and they can't quite hold on, and this often results in flooding of their urine. And this is probably far more devastating than the stress incontinence side, because if you're flooding, there's significantly more leakage happening, whereas with small volume leakage, it may be able to be managed with containment devices such as pads. Other reasons for incontinence include medical conditions such as diabetes, multiple sclerosis, Parkinson's disease, where the signaling between the brain and the bladder is not quite working, so these patients can leak. Another reason for leaking is paradoxical, that they're in retention, so they're unable to actually empty the bladder completely, and therefore they leak urine because they're kind of overflowing the urine. But urinary incontinence is really important condition to try and get on top of, because it's one of the most common causes of patients going into nursing homes. So if you can get on top of these things, you are allowing the patient to live a good standard of life. And of course, when patients do have incontinence, some can become withdrawn, not go out shopping, for instance, or cinema, or taking part in social events. So in women, the causes of incontinence in women are multifactorial. The most likely cause is if they've had childbirth because the pelvic floor has become weak. This, when we're talking about this type of incontinence, this is stress incontinence, where they cough with sneezing or coughing or doing exercise. These women will have leaking, which may be small volume or large volume with the stress. Now, a good reason for this and ways they can manage this is with pelvic floor exercises. The other type of incontinence often seen in women is overactive bladder or detrusor overactivity. And this is where they get sudden urgency, where they don't have time, and they can cause complete flooding of the urination. Again, this can be related to pelvic floor weakness, it can be related to other medical conditions, but a lot of patients it's idiopathic. So I have patients from the age of 10, 12, up to 105 who've got overactive bladder. And many patients live with this lifelong, but there are treatment options available for this. Rarer causes of incontinence include if there's been surgical problems or childbirth, where you can get fistulation between the bladder and the vaginas, therefore they can have constant leakage. Or even rarer reasons are anatomical anomalies, where the ureter, which is the tube that connects the kidney to the bladder, doesn't go into the bladder, but rather goes in beyond the sphincter, so they can leak out like that. Majority of patients, when they do come to us with urinary incontinence, we will always recommend lifestyle changes, and this is as per the NICE guidelines that we use for the management. This is true for both men and for women. Often we'll ask them how much they're drinking, because some patients will read in the magazines to drink lots of fluids, so they may be drinking 3-4 liters of fluids a day, which is fine if you've got no urinary problems, but if you are having frequency and urgency, that might be a bit too much for you. So cutting out fluids overall may be helpful. Not dehydrating yourself, but just reduction. We therefore always get patients to do a frequency volume chart, measuring what's going in and what's coming out. Bladder retraining can be helpful as well, and this is about trying to hold, particularly if you've got overactive bladder, trying to hold on for a little bit longer each time, starting with maybe 2 minutes, 5 minutes, 10 minutes, 15 minutes, to sort of give you that time to get to the toilet before you are completely incontinent. Certain drinks, such as caffeinated drinks, fizzy drinks, drinks with sweeteners, can make a difference to some patients, and therefore cutting those out can be very helpful. This may be a bit tricky because a lot of patients do like their morning cup, afternoon cup, and we've now become much more of a coffee-based society with all the shops opening everywhere. Other natural things can be done is pelvic floor exercises, and this is to strengthen the pelvic floor to help with the signaling, because we know from studies that have been done that if you get a sudden urge, if you squeeze your pelvic floor muscle, there's a reaction called the procontinence reaction. When you squeeze your muscle, the urge drops down a bit. Now, what you're trying to do with the exercises is, and this is when we talk about overactive bladder, is to reduce that urge and gradually increase that time between that urge and you needing to pass urine. For pelvic floor exercises, for stress incontinence, it is about strengthening the muscles. And this is often managed quite well by yourselves or with the help of a physiotherapist. So with urinary incontinence, the pelvic floor is essential for this because it's holding everything in. So to do pelvic floor exercises strengthens the muscles down below. Very important for patients who've had children or patients who've got a weak pelvic floor due to chronic constipation, for example. The way to do a pelvic floor exercise is actually quite simple. The way of thinking about it is, if you need to pass wind and you're in a situation where you shouldn't be passing wind, you try and hold it in. That is a pelvic floor exercise. You do that squeeze and you aim to hold inwards for up to 10 seconds. Now, if you're starting fresh with any type of exercise, you may only be able to hold up to 4 seconds or 5 seconds. You gradually build that up to 10 seconds. You then concentrate a little bit more towards the front. So you do that squeeze, you hold for 10 seconds, and you do the exercises 10 reps each time with a 10-second squeeze, a 10-second hold. And aiming to do this 3 times a day, maybe breakfast time, lunch time, and dinner time. It's useful. You can get apps that can be quite useful for this to help you remind you when to do the exercises. But also, really importantly, they tell you that you're squeezing for 10 seconds, because if you try and do it yourself, the first one might be 10 seconds, but by the 5th one, it might be 3 seconds. And by the last one, it might be, I've done a squeeze and I'm off. Right? So it's useful to sort of have these structured. And by strengthening the pelvic floor, and there's 2 types of exercise. One's a slow one, and for women, particularly the fast twitch exercises, squeeze, contract, it helps strengthen things. This again helps with overactivity because it's helping with the signalings going up to your brain and coming down, and that's what's called the procontinence reaction. And it's helpful for all patients, and the NICE guidelines do state you should do this at least for 6 weeks to 3 months before you go on to any more active treatments in terms of your incontinence. For incontinence, we split this into stress urinary incontinence and to urge incontinence. So we'll start with the stress incontinence side. This, and I'm talking about women here, we've got various options. Once they've tried all the non-surgical techniques, then we've got essentially 3 types of operations available. We can use something called bulking, where you've got the water pipe, it's slightly open, and you put injections of substance such as bulkamid and to essentially close the water pipe down. The data suggests that it works for a number of patients, but it probably doesn't work if your incontinence is very severe and you're soaking through multiple pads. But the majority of my patients nowadays will probably choose this as it's a low risk option. It can be done as day case under local anesthetic or sedation. And if it doesn't work, it doesn't stop us doing the more invasive procedures. Now, any of these procedures, before we do them, we'll always go through our BAUS, which is the British Association of Urological Surgeons information sheets, as well as the guidance that's available from a NICE. There's a decision-making tool that we give to our patients. If the incontinence is more severe or they want a more invasive operations, there's 2 main procedures that I offer and most of my colleagues would offer. One is an autologous sling, where we take a segment of your rectus fascia, which is tissue available from just above your pubis, and then use that as a sling to hitch up the urethra to tighten things up for you. The other alternative is what we call a colpo suspension, and there's various ways of doing this. Can be open, laparoscopic, or robotic. This essentially uses the vaginal tissue to strengthen the urethra. Both of those procedures are far more invasive, do take more time to recover from them, and do have other risks associated with them. Again, this will always be discussed with you and as a patient, and you'll sort of make that decision in conjunction with the tools available to you and in conjunction with your consultant. For men, it's like if your incontinence is a lot worse, then we do have procedures like the artificial urinary sphincter, but this will be offered in super specialist units. For men, it's slightly different. We don't have the bulking agents, don't seem to work as well for them. We do have a sling procedure or a artificial urinary sphincter, but these again are complex procedures which will always be discussed with you in detail, and therefore not really for a short video.